are going to. Hey, so welcome everyone to the final PFCC Partners Community of Practice workshop of 2025. This year has flown by. It's been a bumpy one, so I think we're all fairly excited for a fresh start and a new year as we move into 2026. Um, Thank you all for joining us this afternoon. My name is Lindsay Galley. I'm the Vice President of Programs here at PFCC Partners, or Patient and Family Center Care Partners. And you are all here today to learn more about the outcomes from our Aligning Dollars Through Dialogue Lived Experience Summit that we had at the Putting Care at the Center conference earlier this year. So we're super excited to share those outcomes with you. We have summit participants and planning partners on, so I'll be excited to introduce all of them in just a few minutes. But just a few reminders as we get started. We are recording, and this workshop will be added to the PFCC Partners YouTube channel for anyone who couldn't make it today or to review later. There is live transcript available. So if you need that, you can go ahead and turn it on using the CC button on your Zoom toolbar. And I don't see any AI note takers at this time, but just a note to please make sure that you're not sharing any notes broadly. I know sometimes those AI note takers will share it to everyone in the meeting, so just a note there. All right. So just a quick reminder of who we are at PFCC Partners. This is really what we're all about. We want to see a health system that is transformed into one that works with people and through communities as a partner in their well-being. We catalyze system improvements by centering that human experience of health, and we absolutely recognize the critical role that community engagement must play for every effort at delivering health equity. And now we know that the United States healthcare system is very complex, and this complexity can make it challenging for people to access care that aligns with their needs, health priorities, and preferences. So at PFCC Partners, we believe that when a system that centers care and care processes on the person, there's potential to reduce that complexity and advance a culturally humble healthcare system. So we open space for patients and family caregivers and community voices to drive improvements in this complex system. We know that these voices are a huge catalyst for improvement within systems change. And the team at PFCC Partners has decades of passionate experience partnering with healthcare systems and leaders, engaging people with lived experience in their efforts to improve. So we work to open spaces, creating partnerships that allow for improvement. And then we have an incredible network, the PFA network, our Patient Family Advisor Network, that fills those spaces. This is a community of over 1,100 people with lived experience all across the country who jump into any opportunities available to use their lived experience to really influence improvements in healthcare with their impactful insights and perspectives that they share with us. So that is PFCC Partners in a nutshell. There's so much more we could say, but we have a lot of content to get to. So I introduced myself, but I'd like to also introduce our planning partners who are here to help us present. The first, of course, founder and CEO of PFCC Partners, Libby Hoy. Libby, did you want to say hello?
Hey everybody, happy Friday. I'm really glad to be here to share the some of the outcomes of just a really robust summit and also hear from some ideas that many of you on the call might have. So looking forward to the session today. Thanks.
Awesome. Thanks, Libby. And Gabrielle, our other amazing planning partner.
Hi, hello everyone. For those that don't know me, my name is Gabrielle Altrochet. I'm a independent consultant, but I work a lot in the space of engaging Medicaid folks in particular around their experiences in the healthcare system, and had the really great privilege and joy of partnering with PFCC Partners for this session. So excited to talk about what we found and what people shared with us.
Awesome. Thanks, Gabrielle. And your hair looks so cute. Great. And we will also have the opportunity to hear from all of you. This is an interactive session, and we want to make sure that we leave space for you to inform this important conversation. We'll also hear from some participants who were at the summit, Carl Boyd and Sally Meben, who we will chat with shortly. All right, so to just give a little bit of level setting and context, the Aligning Dollars Through Dialogue Lived Experience Summit, as I had mentioned, took place during the Putting Care at the Center conference this year. This is a conference put on by our incredible friends and colleagues at the Camden Coalition. And it truly lived up to its name. It was a packed, high energy summit that brought together our healthcare partners and, of course, people with lived experience. And what we really try to do in these lived experience summit is flip the table. So at our tables, we had majority people with lived experience and minority healthcare partners, or at least we tried to. um, everyone in the same room to have, really real and honest conversations about a specific topic. And our topic for this summit was how value-based payment models can better reflect what actually matters to people receiving care. So throughout the day, we did engagement. We were actively in conversation, so many incredible conversations. And together we are our building, I'm not going to say we built it there, but are continuing to build a shared understanding of how access, affordability, and the overall care experience directly shapes the true value of care, and of course, why engaging the perspective of people with lived experience from the beginning is essential to these conversations. So here are the objectives from the summit. I also included a picture from the back of the room. It was a packed room. We unfortunately had to turn away about 20 people because we had absolutely no space left. So if you are one of those 20 that we had to turn away and you're here today with us, we are so sorry, but we're so glad that you are here. Yes, lots of energy within this room. So our overall objectives for the summit was to first explore how lived experiences can drive meaningful innovation in payment models to ensure that healthcare dollars are aligned with equity and value as defined by patients. I think that's key. The second objective was to participate in activities to exchange knowledge and power, to experience true collaboration between health plan leaders and the members they serve. So again, this was an opportunity for our health plan leaders and healthcare professionals to actively experience what patient-family engagement is and how impactful these conversations can be. And so finally, which is what we continue to work on, our final objective is to create a co-designed key consideration to support health plans in implementing payment models that are aligned with patients' needs and priorities. So we have a start to that based on our conversations at the summit, but again, invite all of you into the conversation to help us continue to create those key considerations. And I am going to wrap up with just a few big heartfelt thank yous to our entire planning team. So we heard from Libby and Gabrielle, who will be presenting today. We also had Brittany Jackson and Naomi Williams from our team, as well as Melinda Karp from the Center to Advance Consumer Partnerships. This was 100% a team effort. We couldn't have done it without any one individual. So just wanted to thank everyone for your support there. And then just a few more thank yous. gosh, we had the privilege to be around so many incredible people. So I think thank yous all around to also all of our participants there. But more specifically to first Purvo Rawal, who joined us to do kind of a level setting for the participants around value-based payment. Purva is the former Chief Strategy Officer for CMS, Center for Medicare and Medicaid Services, CMMI, their Center for Innovation. And then we also had a panel which included two health plan leaders, Michelle Studebaker from Care Oregon, and at the bottom there, Judy Zerzan from Washington State Healthcare Authority. And then, of course, two people with lived experience, Laura Carroll and Karen Edwards. So big thank yous to all of those who participated and stepped up to the plate to share their thoughts and perspectives on this important topic. So with that, I am going to pass it to Gabrielle. We had a series of very active conversations in our small room. And the first started out with table discussions focused on three priority areas. So I'm going to let Gabrielle take that away and share some of the outcomes there.
Great. Thank you, Lindsay. Yeah, so really interesting. So just to give folks a tiny bit of the methodology here, basically during our table discussions, we had folks add ideas to sticky notes. And so those ideas came in lots of different forms, in phrases, in words, in full complex sentences. Um, but they were centered around three main areas: patient experience, affordability in healthcare, and access to healthcare. Um, and so we then put all of those, all of the data from those that folks had shared on those sticky notes into into a document, and then went through and both manually categorized them to try to understand the themes and group them into main ideas, and also ran them through AI just to kind of get a second sense of whether we had missed anything. And so from those, we really came out with several both big ideas and specifics within those that I wanted to share. Um, so if we start with access, what we really heard, and a lot of this is going to sound like, yeah, of course, right? Like, yes, we've heard this before. But I think we talked about that as a group, and it's so important that even if it's an idea that we've heard before, that we really sit with the fact that it's still so relevant to folks, that this is what is still in the healthcare system, what feels most salient to people. Um, so in terms of access, the broad theme is that folks are wanting a simpler system. That the healthcare system as it stands right now, it's too complicated, it's difficult to navigate. And so specifically, what people really value, what we heard was one, a real interest in integrated care delivery models, meaning pairing clinical care, like, seeing your PC, like your primary care provider, with other types of services like housing, like access to food, like, connections with other types of resources that get to those social drivers of health. So, for example, like building a clinic within an affordable housing unit, or offering other services within that primary care clinic. The other thing that people really expressed interest in, or a desire for, is community-based care delivery. So that people were talking about mobile clinics that are going out into the community, right? And like providing those services there. More in-home services for folks that are either older adults with complex care needs, or just anyone with complex care needs for whom leaving the house is difficult. Like having more of those in-home care options is a real priority for people. And then the third piece, which that impacts everyone is just more support navigating the system. So having peer navigators, maybe that's community health workers, but just peer navigators or people to or case managers to kind of help people problem solve as they encounter difficulties navigating this very complex system. Another idea that came up in that was also just making systems more user friendly, right? So there's both the adding help with the navigation, and there's also just like, can we build something a little bit simpler for people to use? Um, Around affordability, the big thing there, and I don't think this is going to be surprising to anyone on this call, is affordability is a major concern, right? Even for folks with coverage. So we're not just talking about that healthcare is affordable because someone is uninsured, but that affordability is really a challenge, even with either private coverage or government sponsored coverage. So some things that the tables talked about, one was really having insurance plans with reasonable coinsurance, meaning reasonable deductibles and copays. Um, that you don't have to be put at or like not receive care because of the financial concerns around the copays that you have. Similarly, insurance plans with adequate coverage of sort of the basic stuff, right? Also, people are really interested in in services that are non-traditionally covered. So again, some of those services that get to the social drivers of health. And then finally, people talked a lot about the limitations in the like wanting more flexibility and updated calculations around poverty levels for government-sponsored programs. So if we're talking about Medicaid, for example, that the poverty line is really outdated, and that a lot of the rules don't account for the complexity of people's lives and can keep folks from being eligible who really ideally should. And then in terms of experience, patient experience, well, the thing that came out time and time again in the data is that provider interactions are really what's driving patient experience. So the quality of the interactions that people have with their providers, that's really what drives their experience. And so therefore, what people value is first and foremost, having providers that with for whom they feel they're given respect, that they're given empathy, who have cultural competence, linguistic competence. People described like feeling like they were providers who communicate clearly with them, providers who communicate respectfully, who like really, give them all of the options, that kind of thing. Another thing was people wanting systems that really value their own time. So, that we place a high value on providers' time, which is appropriate, but that also the patients themselves, they take time out of their day, miss work, whatever it is, to come to an appointment. And so, clinic models where patients are maybe compensated for extensive wait times or find other models that where systems find other ways of either compensating or demonstrating value for people's time. Another big one was, unsurprisingly for this group, is partnership with patients and their families, right? So both in the sort of formal structures like advisory committees or work groups, but also just it's really important to me that my family be part of my care planning discussions, right? Or like it's really important to me that my caregiver or my family be be involved in not just my care at home, but also my care and interacting with the system. And then finally, and I think this one is really interesting, is patients really value systems that enhance provider well-being. So folks do not want their providers to be burnt out. They don't want their providers to have to be running from, appointment to appointment. They want their providers to exist and work in a system where there's enough time for them to spend with them, and that where there's workforce development, where their providers too are sort of well supported in that. So that's high level what we saw from those table discussions. Again, some really rich findings. I'll pass it back to Lindsay.
Thanks, Gabrielle. And I'm actually going to pass it to Libby because we had another activity to round out the day and one that we love doing and always learn so much from. So I will let Libby describe the outcomes from that.
Great, absolutely. And I have to give a shout out to Erica Steed, who introduced me to the procedure of a stop, continue, start. And it's such a great affinity exercise to really move some of those discussions into action. Like, what would we start doing? I'm sorry, what do we need to stop doing to really create the kind of changes that we want to see moving forward in the health system? So really specifically taking the ideas from the discussions and then moving that into what do we need to start doing? I'm sorry, stop doing. I always do that. And then next, what do we have in the ecosystem that is working or that could be nurtured to work even better? So what do we need to continue doing? And then finally, what are we missing? What actions do we need to take and to initiate to again build the health system to be equitable, to be high quality, and to be financially solvent? So that was kind of the activity that we did. We always want to capture every voice in the room. And so this starts as an individual activity where each of the participants at the summit gave their responses. And that way we're ensuring we're capturing every great idea from every individual and then summarizing those into these themes that you see here and on the next slide. So starting one of the themes and you'll see a lot of overlap with, or you'll hear rather, a lot of overlap with what Gabrielle just described, because now we're kind of again taking those opportunities and moving them into action. So shifting from a profit-driven to a people-driven health system. So what do we need to do that? We need to stop assuming the metrics we're using is inclusive of all the dimensions of quality and value. So really taking a look at how are we measuring quality and value, centering on patients and people with lived experience. So again and again heard co-design, designing solutions with the end users of the system in mind, with people and with the providers, right? That's important. Who are the end users and how do the players upstream impact that final kind of clinical encounter? And I think that's a really important piece for us to think about to really to start connecting the dots between our health plans and what's covered and the transparency or lack thereof and the drivers up above the actual clinician in the room with the patient and the family. We really need to start making those connections. Then simplifying the system, which we heard. And, again, Gabrielle, I think we had this conversation. It's like, duh, yes, let's simplify the system. But how do we really do that? And how do we really think about that? So, removing unnecessary layers was suggested specifically around pre-authorization. Like, how much time does that take? How much inefficiency is built into that whole system? We need to continue to invest in case management to help folks with navigating that healthcare system. So those were some of the ideas coming forward in terms of how we simplify the system. And I'll pause there to say we had so much input. We had so much input. We had about 50 people in the room, and everybody had probably at least 10 ideas. So we'll provide a more comprehensive look, but we also want to invite each of you on this call to add to our knowledge base together. So on the next slide, then, continuing with some of the themes we heard, humanizing healthcare through relationships. And that might sound really soft, but people were very specific on what that might look like. We needed to stop underestimating the time it takes to build relationships and really invest in that time. Allow for providers to have more time with their patients and family caregivers. Help design new and modern systems for engaging in different ways over, outside the clinical relationship even. So really just starting to invest in relationship and make space for it. Um, that was one suggestion. Innovate and exnovate. I love that term. We keep innovating, and it's like building on this big Lego system. We need to exnovate. We need to take away some of the things that are no longer serving us. And so really thinking about how do we do that? Um, we need to start having transparent methods to balance the human needs in the system and the financial needs. Like, let's look at that together and let's, call a spade a spade. The financial has to be a part of the conversation, and patients and families want to have part in that conversation, but are often excluded through lack of transparency there. So, starting transparency, continuing the shift from fee for service, and really, again, no, normalizing co-design with the end user. So we heard that quite a bit. And then strengthening, sorry, communities. Can we start reimagining care models um, with more remote and virtual options built into them? So, thinking forward, can we start thinking how non-clinical roles can support the clinical relationship and can support patients and families to really be engaged in their care? So, again, so many really fantastic specific ideas that will continue to move forward, but um, hard to summarize. But wanted to organize how we presented these ideas to you today. So I hope that you'll again join us in thinking about from your perspective, from the work that you're doing every day, or the your patient and family caregiving experience every day. What are those things that we should stop doing today? What should we build on? What's really working? And then what should we start? What should we innovate? So, invite you to start thinking about those ideas. So, as we looked at all of the data and all of the responses we got back, on the next slide, we kind of noted some interconnecting themes. So, across the table discussions into what actions should we take. And these were, really the three sort of big buckets across the health ecosystem. Humanizing healthcare through relationships, respect, and power shared. A lot like the HCP land paper, which called for patient experience. Creating a simpler, more integrated system that meets people where they are. Um, Again, access, right? Kind of similar to that bucket from the HCP land paper. And then making healthcare affordable and equitable by transforming financial and policy. Again, affordability. So it was also kind of striking me that that's a strong reflection of the triple aim, which came out in 2001, right? Improve experience, improve access, and improve affordability. So these aren't new buckets, but the ideas and the thoughts behind the innovation that could really get us there. The other thing that struck me about these three themes is the connectedness of every player in the healthcare system to deliver on these. So I think a lot of times when we think about humanizing healthcare, we think about the clinician and the patient in the room, right? We think about, does that clinician listen, active listening? Does that clinician, demonstrate respect? But the activities that take place way before the clinician gets in the room with the patient are equally responsible for how we humanize healthcare. Does somebody walking into that room have transparency about how they're going to be charged for that visit and understand, does the clinician have enough time to really spend with that patient or family member, or are they beholden to financial policies that limit that? So I want us to really expand our thinking about who's sort of responsible for helping to create this system. Similarly, you can see with access, right? That's impacted by not only just the clinician and the patient and family caregiver resources, right? Access a lot of times defaults to, well, can people access care? Is a care available? How does each player in the system of the health in the health system contribute to access? And I think that's what we need to start thinking about. Not that's their responsibility over there. That's the health planner. That's on the clinician. But how do we work together across silos and importantly, engaging people with lived experience? And finally, with affordability and transforming financing and policy. That's what this whole summit was about. Patients and families are rarely consulted about what adds value to care. And I think that that's not just a nice thing to understand what patients and families think of as value. It's a critical, essential financial aspect to the care that's given because we want to pay for the things that are actually producing health for people. And we're not going to know that unless we're actually talking to the people as well. So it's not to replace any of the actuarial information, the data that's available. It's another lens that's really important, right? So anyway, I just wanted to put that out there that we're really starting to see the responsibility of each player in the healthcare system for each of these areas. Interconnected. All right. With that, I think we're going to do a little temperature check. And we just kind of wanted to see, do these themes resonate with you? Again, I know that they're large buckets, but how are you responding? Oh, am I starting the poll, Lindsay?
Nope, I just launched it.
Okay.
Go
So
ahead.
first of all, just do these themes resonate with you and what you see in the environment from your perspective as a healthcare stakeholder?
And if the poll isn't working for you for one reason or another, please feel free to put any thoughts into the chat as well. We can capture those that way. We have about half of the participants who've responded to the poll, so we'll leave it up for another 15 seconds or so. And I've never done this rating type poll before, and it's looking pretty neat on my side, so I can't wait to share it. I
Well, I
know,
see
Sally, it's got
that.
to be hard to choose. Sorry, go ahead.
Oh, I was just looking. I'm still at the yes no poll and just wanted to. I'm always relieved to see that these themes are resonating so that we know we aren't too far off the mark.
Oh, absolutely. All right, I'm going to end and share. And Libby, do you want to share any reflections?
Um, I would love to. I'm not seeing the polls.
Oh, you're not?
No. Or
Can
there we go.
everybody else see the results?
All right.
I'm
Well,
seeing some
I think
head. Oh, maybe because you're a co-host, Libby?
I think so.
Okay.
Why
Well,
don't
yes,
you let me know how it's looking and we'll
Yeah, you were seeing the resounding yes,
yes.
that this did resonate. And I mean, oh, thank you, Gabrielle. What a great idea to
There we
put the
go.
results in the chat. Yeah. So yes, you can see. So we asked, if implemented, would these be impactful, somewhat impactful, not as impactful? And obviously resounding very impactful for each one of these, which I know it makes it really hard to prioritize. So
It does. It does. Well, I suppose that lets us know we have a lot of work to do. But I'm curious if anyone else has any other thoughts on kind of what you've heard thus far and what you're seeing in the polls. All right. Well, with that, I think we'll just move right in to the panel. We've got some folks on the line who participated with us and shared their views and wanted to invite them in. So, Lindsay, I'm going to pass over to you.
Yes, thank you, Libby. I know I was going to say I know a few people who would be interested in sharing their thoughts. So I would invite you all to join me in welcoming Carl Boyd and Sally Meba, and I'm going to give both of them just a moment to introduce themselves and just have a couple questions for each. So, Carl, go ahead.
All right. Hello, everybody. I know a lot of you already on the call, but my name is Carl Boyd. I am a volunteer board member, ambassador, and CAC, which is Community Advisory Council for the Camden Coalition. Also, in my day job, work at Center for Family Services. I work for Head Start. I'm a family engagement coordinator. And I'm just looking forward to a deeper conversation and like what everybody is saying so far. So thank you.
Great. Thank you, Carl. And Sally.
Hi, everybody. Thanks so much for inviting me. This has been so interesting to see the what was discussed at the summit shared back in this way. I am the director of programs at State Health and Value Strategies, and we are a program that is funded by the Robert Wood Johnson Foundation to provide free consulting services to states in support of their Medicaid and marketplace programs with the goal of helping them transform the health and healthcare systems. Just a small task there. And we are based at Princeton University. And yeah, really looking forward to the conversation.
Great. Thank you, Sally. And thank you, Carl. Yes, both Carl and Sally were participants at the summit. So it was so cool just being all together in person too. And apologies again for our small room setup, but we made it work. We got really comfortable. All right. Well, I'll start with I'd just like to hear both of your kind of initial reactions to the common themes that were shared here today. So I'll start with you, Carl. And we've had a lot of conversations, and you really emphasized the need for mutual respect, which came up through the themes really clearly, especially when engaging people with lived experience and co-designing systems. So I'd love if you could just describe, why this is needed and the impact that, it has had on your engagement as a person with lived experience.
Well, for me, like I said to you in some past conversations, people always emphasize respect. And respect is important, but I always emphasize that you have to have mutual respect because to me, you both have to meet in the middle. So as far as patients, as far as medical providers and professionals, when you have that mutual respect, that's the only way you're going to meet in the middle. Like I look at like the comments of Miss Connie and all of what she's written, and the only way this works is to have mutual respect because both people or multiple people come to the table have to be willing to listen to each other. Sometimes people um, they speak in order to give out a fast answer versus speaking from a place of listening. And we have to have people speaking from a place of listening in order to, institute these different things. Um, and with the mutual respect, it also gives patients a chance to be a part of the co-design as we talked about.
Okay.
I think this is important in order to have a more cohesive design or a more cohesive system. This gives opportunities for us to learn from each other. This also gives opportunity for the patient to have a stake in their own well-being. A lot of times in the past, maybe things have just been one-sided. You listen to the doctor, you listen to the medical professional, and that's it. But through dialogue, we all, as the old adage goes, we all learn something new every day. So I respect the fact that individuals have their medical degrees and they have PhDs and different things behind their name. But sometimes just listening to that patient will open up another idea that you can implement. Vice versa, I think the patient needs to be listening to the medical professional, because after you have that conversation, you may tell that medical professional something that you forgot about or something that is really important. So these dialogues are super important. I was in the hospital for 3 months, and I wasn't able to go home for over a year. I was in two hospitals and a nursing home. I had COVID pneumonia. So there was a point in time where I was intubated and I was actually, like I said, I couldn't speak. I was sedated, so my voice couldn't be heard. As soon as I was able to speak and talk again, I did that. But to what people were saying earlier about also having their family members involved, I needed to have those people involved because I needed them to speak for me at a time that I could not speak for myself. So all these conversations are just super important. You can't sit there silent, not saying anything and letting people know where you are in the process. I think it's important. I think that when you let people know where you are in the process, they have a chance to reevaluate and look at things and to help you in a deeper way. So we have to have these mutual conversations. Therefore, we have to have mutual respect.
Hmm. Well said, Carl. You exemplify the teachable spirit too, and just describe it so eloquently. I always appreciate that. So thank you. And thank you for sharing your experience with us as well. Appreciate it.
And no problem.
Um, and a big part of making all of that work is ensuring that it is affordable. So everything that you went through,
Yeah.
also one of those pillars. And so Sally, when we prepped for this, we talked a lot about affordability and how it's shown up in your own work, research that you talked about, and just the political spectrum. So I just invite you to share, a little bit more about kind of that background and why that stands out as really important to you.
Yeah, thank you. And thank you, Carl. That was really so insightful. So, yeah, I mean, I think at my table, a theme that did come up repeatedly was the struggle around affordability, and that point of like having access, but access not necessarily, so having coverage, but coverage not necessarily meaning that healthcare is affordable. Um, and so we see all the time, and in my role at State Health and Value Strategies, I'm really looking at the healthcare system from like a bird's eye view, right? We try and work with all 50 states. We're often translating a lot of what's happening at the federal government down to states and sort of vice versa. And I think from a policy perspective, it feels very much as if we're in the midst of a healthcare affordability crisis. And you see that in the number of people who are saddled with medical debt, which some states have tried to take steps to address, but they're really limited in their ability to make a dent in that problem. And then we saw it like with states, or we hear it from states that run their own Affordable Care Act marketplaces. And, where consumers are now faced with these huge increases in premiums as a result of Congress not extending the enhanced premium tax credits, and those marketplaces are getting calls into their call centers of people who are really panicked and desperate about how they're going to be able to afford care, and are they going to have to go without coverage. But I think one of the bright spots for me in thinking about the affordability crisis is where it potentially takes us. It's like, it's so bad that it feels like there's only room, hopefully, to improve. And some of that is confirmed by a survey of 1,000 adults that the Robert Wood Johnson did recently, the foundation did recently, where they found that 90% of adults agree that our class and zip code should not dictate our health. And that in the wealthiest nation on earth, no one should have to choose between putting food on the table and affording the medications they need to survive, right? So that's like across the political spectrum, that's across racial and ethnic groups, that it was a broad sample, a representative sample. So I think that is super encouraging for thinking about how people really want change. Um, and from the same study, 70% of people say they believe it's possible for the US to make positive and bold changes to fix the system. There are obstacles that they perceive, and some of those are things such as politicians being beholden to corporations, um, and the inability to drive towards change if we are going to have to rely on Congress, but that they still believe that change is possible and they really want to see dramatic change. And they also want a government system as compared to a privately financed system, which for me, as someone who I suppose has only ever worked in government, I really see the solution to the core themes that were identified as through a government funded system. In any case, so yeah, just wanting to share that, like that very much resonates with, I think, what's the conversation at the policy level, and the way that healthcare policy people and state leaders are talking about the challenges that we face in the healthcare system.
Absolutely. Wow. Thank you, Sally. I so appreciate that, the perspective that you bring. And I think it is a balance of acknowledging the obstacles, but also, being reassured by what we're seeing, across the entire political spectrum. So it is reassuring. Thank you. All right. So, last question to wrap up our conversation, in thinking forward, is, how will or can you use this information in your own work? So, Carl, we had talked a little bit about healthcare navigation. You had a really great
Mhm.
analogy. So I wanted to just see, how can we use this information to continue the conversation, because that is a big part of it, is just continuing the conversation, continuing to learn. So how will this inform your future conversations?
So, I mean, when we had our conversation last week, I spoke about the importance of navigation, and often when I'm in different meetings and different places and spaces, I'm constantly talking about how important navigation is. So if we're in a room and we have a table in that room, and I dump a whole bunch of resources on that table that can help you out, that can maybe solve some problems, that can make life easier, I've not done you any good by dumping all those resources on the table. Because if you don't know how to navigate those resources, it's kind of like me putting gold on the table and you can't spend it. You know what I mean? Like, you have to be able to navigate. You have to have a support system in order to navigate these systems. Like these, a lot of these systems are very complicated. Maybe not so much to us, but to the average person, like they're like throwing their hands up. So in these conversations, we have to talk and kind of continue to push the needle towards navigation, push the needle towards maybe having community health workers, social workers, um, help us in this vein. And even to what again, Ms. Connie, I gotta refer back that patient awareness institute idea she was talking about. That is something that could give people, maybe not, you're not going to have a degree in navigation, but you would have a little piece of what it means to start moving the needle. And we have to have these processes in place. And I think that systems are getting better to some level and are realizing this, but we do have a long way to go with that. So,
Yeah. Thank you, Carl. And I always feel reassured when, we have big discussions like this and there are so many ideas that align, it almost feels like you have an army behind you when you go into those conversations that you're
Right.
having. I have all of these people who are saying the same thing as me, so that's always reassuring. So thank you, Carl. And Sally, similar question. I know we were at the same table for our discussion, so heard a lot, but just wanted to invite you to share, what you learned and what you'll take with you into your future work.
Yeah, I mean, I think to Carl's point, we're about to see a Medicaid system that gets that's going to be even more complicated to navigate. Or sorry, to Carl's points about, or it's interesting, Carl, to hear you say that you think it's gotten easier to navigate, because my fear is that we're going to see, at least in Medicaid, right, it's about to get more complicated. And the idea that like we've made progress and now we're retrenching is super frustrating. So I'm speaking to the fact that, as of January 1st, 2027, eligibility for Medicaid for the expansion population, so adults, will become, or a portion of the adult population will become contingent on meeting a work requirement, which is 80 hours a month of work. And of course, people will be exempted, but the challenges of exempting people on the basis of, their diagnosis will be challenging to implement for states. And so just to say that I think as this system is about to become more complicated, I'm encouraged that states are also, as they've just launched these new advisory committees of people with lived experience of Medicaid, looking to those committees to think about some of the design considerations in putting together what the work requirement will look like in terms of how people will, provide the information to back up that they've met the requirement or that they are exempt from the requirement. So to tie this sort of back to what Carl was saying is, it's really a system that you can't design a system that has to be navigated by people without the people themselves. And so, states are making very small baby steps towards that, right? This is the first time that Medicaid programs have ever had to engage people with lived experience of Medicaid and hear from them about how their programs and systems work for people. And in some ways, it couldn't be better timed, because this is going to be such a huge new level of administrative burden for folks who receive coverage through Medicaid. So just, I guess my long point here is to say that definitely continue to take back how invaluable, right? Hearing from people with lived experience of the healthcare system is. Like, it's so key, and we can't build a better or new system without folks who can testify to what that experience is.
Absolutely. Well said. Yeah, I know we always say, once you engage with people with lived experience, there's no going back. You can't work any differently. Well, thank you both so much, one for participating in the summit and for joining us here today to share your additional perspectives. I really appreciate you taking the time to do so. So thank you so much. And to wrap us up, I know we have just about 5 more minutes left. We want to open it up to everyone else now. So we've heard from Carl and Sally and how this will impact their work, but now I'd like to hear from all of you. So what we're going to do in the last few minutes is a chat waterfall. So I'm going to ask you all to respond to this question in the chat, but do not click send quite yet. So my question is, how can this information impact your work? I know we've shared a lot, a lot of very high level information. But if there was anything that stood out to you that you can take back and, start conversations with, we'll give you 2 minutes to share in the chat, but don't press send yet. How these themes and this information can impact your work. And by work, for people with lived experience I mean your partnerships, your future conversations, if you're in the health system more directly. Add your response to chat, but don't press send. Give you one more minute. Right. Hopefully that was enough time. I'm stalling a little bit. Okay, so now at the count of three, I'm going to ask everyone to click send on whatever message that they created in the chat. So 1, 2, 3. Click send. Oh, oh, there it goes. And that's our waterfall. Awesome. Okay, so we have a few comments in here, and I invite Libby and Gabrielle to help me look through some of the comments and pull some out.
Yeah, I think Ellen has a great comment, and that is this feels like, some really big major challenges. And at the same time, we heard from Sally, that people feel like the majority of people feel that there is a way forward and there is some solutions. So um, how do we get from identifying problems to solving them? I think we get rooms like this together where we have all the stakeholders plus people with lived experience, and we set up formats where these conversations can take place. But interesting. It's a
Mhm.
good question. It's a good question.
Yeah, and Louis, to that point, I think also, the idea in this particular workshop was really to highlight what is important to people, what do people value in their healthcare. And then a different type of connecting decision makers with folks with lived experience is around designing solutions, right? And
Mhm.
so, exactly to your point, like I think the next step is then getting more granular about a specific problem that's been identified, and then really asking, working together between the policy wonks, the providers, the folks that are decision makers in the system, with the end users, the people, the folks with lived experience around that solutioning and
Mhm.
designing those solutions. Because yeah, a workshop like this is going to elicit more of these are the problems and not so
Yeah.
much these are the solutions.
Yeah, so true, Gabrielle. That's the next step. And I like Reginald's comments. We're all in this together, and we have to be able to co-design solutions. And also want to acknowledge Ivy's comment in there too. Yeah, and this is a conversation starter. This is what we're sharing, what we've learned so far. So yeah, I encourage you to use it as a conversation starter. And over the next few months, we'll have more detailed outcomes to share with you in the form of a report to take back. But again, we also invite you to be a part of this effort with us. So yeah, please continue to stay in the loop. We invite you to, yeah, just continue to partner with us. And I know we're right at the top of the hour, so I just want to end by thanking everyone again, our planning partners. Thank you, Libby and Gabrielle, Brittany and Naomi, and thank you, Sally and Carl, too, for joining us today. And then all of our participants here. Appreciate you spending a little time on your Friday afternoon with us. We have a few minutes if anybody has any questions or additional thoughts. can hang on for a few. But if not, just very happy holidays from the PFCC Partners family to all of yours. Thank you again, everyone, and any of the other presenters, if you'd like to say any last words.
Thank you for guys for preparing and doing this. I absolutely coming to every PFCC Partners opportunity I get a chance to come to because you guys pull it all together and I love this. Thank you. Happy holidays.
Happy holidays, Connie. Thank you so much. All right. Well, have a great weekend. Yeah, take care, everyone. We will add the recording to YouTube. Please stay connected with us on LinkedIn. And I know Libby put her email in the chat. So, yeah, any additional thoughts, new ideas, we 100% welcome. So, awesome. Thanks so much, everyone.
All right, take care, everybody.
Okay.